Okay, students, we are on Chapter 3, Drugs Action Across the Lifespan. So the objectives today will be to explain the impact of the placebo effect and the nocebo effect, identify the importance of drug dependence and drug accumulation, discuss the effects of aging on drug absorption, distribution, metabolism, and excretion, explain the gender-specific considerations of the drug absorption, distribution, metabolism, and excretion. So some factors that actually affect drug therapy. Responses in the individual actually can really vary quite significantly. You can have a person who may be really sensitive to medicines, you get a potent response, versus just someone who is maybe very tolerant for some reason, and so they get a little response, or not insignificant. Age can also be a factor. Infants and the very old are the most sensitive to the effects of drugs related to the ADME such as in preemies and newborns and children, and then because their systems are underdeveloped. And then, of course, aging, and that's because there's changes in body composition and organ function. Body weight, again, can be a factor in drug therapy. If you are overweight or obese, the drug dosages may have to be increased for therapeutic ranges to be obtained, or in the desired effect, or you might be underweight and dosages may have to be reduced. Pediatrics, you're usually going to see milligrams per kilogram. That is because the dose is adjusted for the growth rate. In chemotherapy, most of those doses are based on body surface area, which is a calculation of height and weight. Gender can be gender specific. Males and females both respond differently to drug therapy. Related to our system actually has functional differences. They just function differently, and perceptions and experience of the illness are different as well. And then illness, pathological conditions may alter the ADME, like renal failure. So let's go on to the placebo and nocebo here. A placebo, basically, this effect, it's a patient's positive expectation can positively affect the outcome. Now, a placebo really, it means I will please, but when someone gets a placebo, and they usually use these in like studies, there's testing a drug, so one group gets the drug, one group gets the placebo. And the placebo, it means just nothing is in there, but psychologically, our attitudes and expectations actually play a major role in our response to therapy and in our willingness to take the medication as prescribed. And if you get a placebo, you think you're actually getting the medicine, so that can affect how our attitudes and our expectations. On the other hand, we have the nocebo effect, which is the patient's negative expectations and can result in a less than optimal outcome. Now, nocebo means I will harm in Latin, and so what happens here is the nocebo actually affects in our psychological mind, in a psychogenic illness, especially if you're in stress-related problems, the patient just worries about their condition or their treatment, and they don't think the medicine's going to work. Everything is negative. That's why it's a nocebo. Everything is negative. Their expectations are negative. Their outlook is negative. So their attitude is negative. So you get this negative effect. And we can help them try to diminish this by having a positive mental attitude yourself and emphasizing the positive aspects of the therapy. So just remember, the placebo or the nocebo really is a drug dosage that the placebo itself is just a drug dosage form. It doesn't have any pharmacological activity whatsoever. There's no active ingredients in it. It's just false. The ethical concerns for those, basically, we don't give placebos for like pain management because the American Pain Society, as well as the Agency for Healthcare Policy and Research, really recommend the avoidance of deceitful use of placebos in current clinical practice. Guidelines for pain management. It's thought that the deceitful use of placebos in pain management violates the patient's right to receive the highest quality of care possible, and you would actually be contributing to that nocebo effect. So let's talk about tolerance. Now, tolerance to medication, it means that you have to have a higher dosage of medication to produce the same effect that a lower dose once provided. So, and this can be caused by a psychological dependence or by just the individual's metabolism of the medicine. So there is a difference between tolerance and drug dependence. Now, drug dependence, the person's unable to control his or her ingestion of drugs. I mean, they'll take it no matter what. And physically, the person can have withdrawal. If it's a physical dependence, the person can have withdrawal symptoms if the drug is withdrawn. And psychologically, a person is just emotionally attached to the drug. Tolerance, and older people really worry about becoming addicted. But less than 1% actually ever become addicted to a drug. And a lot of times, we're thinking of these scheduled drugs, the narcotics. And so people do worry about that. But it's really important for us to help our elderly or help our older people that it's okay for them to take the medicine, that it's going to help them, because that's what we're really trying to do, is we're trying to improve their quality of life. Now, the accumulative effect, the drug, this is when drug accumulation occurs when the next dose is given before the previously drug has been metabolized or excreted. This is how you come up with drug accumulation. And what happens if it accumulates too much, we get into drug toxicity. So we try to avoid this by giving medicines at the prescribed time that they are prescribed to be given. So they give you an example of alcohol. Eventually, if you ingest enough alcohol, the person first they become drunk, but then or inebriated, but then their rate of consumption is soon going to exceed the rate of metabolism and the excretion of the alcohol, and then you would get into alcohol toxicity. Let's see. Factors that influence drug reactions. Okay, so we are going to going back over the ADME, because each of these are affected differently. So in absorption, and remember, this is where the drugs are absorbed in the body, most commonly in the GI tract. So we send a lot of things by PO route, but other routes include the parenteral and toxal. As far as age goes, the pediatric and geriatric patients really require special considerations for their med administration. In premature, the slower gastric emptying time may allow increased absorption. Okay, so let me backtrack just a little bit. In absorption, which again, most of the time we give drugs PO. Okay, so it's going to be absorbed via the GI tract. That can be influenced by a lot of factors, such as the blood flow. Our circulation, how much can be absorbed at one time. Our gastric pH can make a difference. Our gastric emptying time can make a difference. The enzymatic activity of the stomach itself and the enzymes that are there can actually make a difference. The permeability and the maturation of the mucosal membranes can make a difference. And then concurrent disease processes. So again, such as here where it says premature, slower gastric emptying time can allow for increased reabsorption. These things all will be affecting the absorption of the medication. And of course, most of the time we're dealing with the very young and the very old that are the most susceptible to these changes, or these problems rather. So like neonates, you know, their ion absorption is erratic and they have reduced gastric acidity. Infants, their topical absorption can be increased. Remember, they have thin, very well hydrated skin. So things like for the geriatric patients, if they have a patch, a transdermal administration, it's often difficult to predict because their dermal thickness decreases with aging. So that could actually enhance absorption. But factors that actually could diminish absorption could be if they have some drying and wrinkling, dry skin and wrinkling, and they're a decrease in the number of hair follicles. So each age group can be differently affected. Okay. So again, let's think about what types of PO medicines we get. Infants and older adults often lack sufficient number of teeth for chewable medications. And of course, chewable tablets really should not be given to children or to any patient who has loose teeth. Also, geriatric patients have a reduced salivary flow, which then makes chewing and swallowing more difficult. So sometimes we have to look at these things too. You might have to go from a tablet to see if the medicine is actually in a liquid form. We might have to go that for easier swallowing. But there are things that we can't open up and mix, or we can't crush, and that would be things like time-release tablets, enteric-coated tablets, sublingual tablets. None of those should ever be crushed because this actually increases their absorption rate and thus potentiates the problem of toxicity. Newborns and geriatrics both have a reduced gastric acidity, and then the prolonged transit time is as compared to adults, with younger adults. I think I'm getting ahead of myself here. So you really have to look at your patient population, their ages, the individual problems they may be having. All that plays a part in factors that actually influence the absorption of the medication. Even as far as the rate of speed that the intestine is emptying, that can play a part. Also, gender. Generally, women's stomachs empty solids more slowly than a man's, and women have a greater acidity than men. Thus, that can slow the absorption of certain types of medications. There's also an increased potential for toxicity by more contact time in the stomach for potentially ulcerogenic drugs such as the non-steroidal anti-inflammatories. So we're talking like Aleve, an ibuprofen, those type of medicines. Women also have a lower gastric level of enzyme alcohol dehydrogenase, which is needed to metabolize ingested alcohol. So that can play a factor. Also, body weight and drug distribution. We're going to cover. That'll be covered more in Chapter 4, but that can actually aggravate the higher blood alcohol levels in a state of intoxication in women as compared to men. So again, all these factors are affecting absorption. Now, factors that affect distribution. Okay, oops, I went ahead of myself here. So ways in which drugs are transported, again, the distribution is the ways in which drugs are transported to the site of action. That really depends on the pH, body water concentrations, fat tissues, protein binding, cardiac output, again remember that blood flow, that circulation, and blood flow. Infants, they actually have a higher total body water content that requires higher doses on that milligram per kilogram basis. They have lower body fat. And they have reduced protein binding in neonates as well. Okay, so the significance of this is that infants really have a larger volume of distribution for water-soluble drugs because they have a higher body water concentration. and thus that's why they require that higher dose on the milligrams per kilogram basis in comparison than that to an older child or even an adult. In aging persons, we have lean body mass and total body water is actually decreased, and total fat content increases. So you're going to have different. Most drugs that are highly fat soluble then require a longer onset of action. And then remember, they're going to accumulate in fat tissues because they're highly fat soluble. And if it's lipid soluble, remember they love the adipose tissue. So it's going to sit there and wait in that adipose tissue, and therefore you can run into some problems. Okay. Women actually have a greater portion of body fat. That produces a higher blood level as compared with that of a man. So that is a gender-specific problem here for this. And drugs that are relatively insoluble are they can be transported in the circulation by getting down to the plasma proteins, especially remember albumin. And protein binding is reduced in preterm infants because of their decreased plasma protein concentrations. They have a lower binding capacity of protein, and then they have a decreased affinity of protein for the drug binding. So our preemies run into difficulties. So there's not much difference in the albumin that exists between the albumin protein in men or women. That's pretty relatively the same. But there are differences between the globulin proteins. This would be like the corticosteroid binding and the sex hormone binding globulins. So if you have an adult who is more than 40 years old, the composition of their body proteins start to change. And the total body protein concentrations basically are unaffected. But so your albumin concentrations gradually decrease, and then your other protein levels actually increase. So that's why it kind of relatively stays the same. But as your albumin levels do diminish, the level of your unbound active drug increases. Because remember, our albumin is what carries the molecule of the drug, and when the molecule of the drug is attached to the albumin, then there is no physiological activity response. It's when it becomes unbound and it's free floating in the blood that it's going to attach to the receptors and alter the physiological activity. Let's see. I think we've pretty much said everything we can about distribution. Let's move on to metabolism. Of course, the metabolism, remember, has to do with the liver, which is our biggest organ for that. And so it's the process where the body inactivates the medications, primarily in the liver. Infants, enzymes really take several weeks to a year to develop. Older adults, the liver cells actually are going to decrease, and blood flow decreases. And in all ages, genetics, smoking, diet, other medications, and liver disorders are going to affect the metabolism of the drug. Drugs that are extensively metabolized by the liver can have a substantially prolonged duration of action if you have a hepatic blood flow problem. So that enzyme system, which is, even though it's present at birth, it matures at a different rate. And so the liver weight, the number of functioning hepatic cells, and the hepatic blood flow, again, decrease with age. So there comes in your problems. And then if you have a disease process that's thrown in there, then your metabolism can be affected at any time. Now, when you hear me talk about liver enzymes, there is a particular liver enzyme that actually deactivates a lot of drugs that we actually intake. And that's the CYP3A4 component of the cytochrome P450 system. Now, all that sounds all very complicated, and it's all a little bit is. But you need to know that when that enzyme system is affected, then you can be in serious trouble, because that CYP3A4 actually metabolizes more than 50% of all drugs that we intake, and it's 40% more active in women. So if you're taking like erythromycin or prednisone, they can be metabolized faster in a woman because our CYP3A4 is actually more active than a man. So there are some differences, but you may hear that P3A4 of the P450 system, of the cytochrome P450 system. You might hear that again, especially as you if you advance on in your nursing career. So just know that that system is in the liver. It detoxifies. It breaks down, inactivates those medications. Women have more of it. Women have, well, not really more of it, but it's more active in women than in men. Let's see here. So in our excretion process, again, the kidneys are mainly involved here, but we do excrete some things through feces. The metabolites of drugs, which are really just the products of metabolism, and sometimes the active drug itself, it's going to eventually be excreted from the body. And of course, you remember it's the kidneys, which are the renal tubes of the kidneys actually, and through the GI tract with feces. Preterm infants have a 15% of the renal capacity of adults. So you see they have a reduced amount. So it's going to take them a little longer to get rid of all that medicine. Neonates only have 35%. A full adult function occurs at between 9 and 12 months. So dosages are adjusted because of that. So as the body ages, then the important physiological changes that take place in the kidney include there's decreased renal blood flow, so you have some blood flow issues there, and then there's reduced cardiac output. You also have a loss of glomeruli, and there's a decreased tubular function and concentrating ability. So for our older folks, this is the problem that comes about with them. So the renal function of our older adult patients has to be monitored, and again, those dosages are going to be adjusted to a lower dosage for our elderly, and that's estimated with the renal function and the age of the patient. So you're going to be looking at urine creatinine levels a lot. Okay. All right. So therapeutic drug monitoring. Of course, this is a measurement of the drug's concentration in the blood sample. It's very essential in our neonates, our infants, and our children. Dosage and frequency of medications can be adjusted to maintain that therapeutic level of potentially toxic drugs. And let's see, lost my place, sorry. And we're going to, I'll go back over some of the drugs that need to be monitored. You have in your book, like in Table 3.2, medications that require hepatic monitoring. I'm not going to ask you to memorize all of these, but you really do need to look over them, because eventually you're going to be giving some of these drugs, and then we're going to be asking you, not just me, Ms. Kimberlin and Ms. Davis are going to be asking you, what is a nursing consideration? And a nursing consideration for these drugs is to monitor hepatic functioning. All right. On your Table 3.3, which are some selected medications that require dosage adjustment for renal failure, you want to look over these drugs as well, so that you become familiar with them. There's lots of different ones here, But therapeutic drug monitoring is also routine condition. We also do that routinely for conditions such as epilepsy. So then we're going to be looking at drugs that control epilepsy. So these are the anticonvulsants. So you're going to be looking at like phenatonin, valproic acid, phenobarbital, carbamazepine. You're going to be doing drug monitoring for the cardiovascular medications, that especially like those that cause for if you have a dysrhythmia, and we're going to be giving you medicines like lidocaine or clonidine, propanamide. All those require monitoring. Digoxin is a big one. Lots of people take digoxin, and you do have to know the signs and symptoms of toxicity for digoxin. And we will be doing drug monitoring for that as well. There's lots of things that we do. Antibiotics are a big one. Again, like gentamicin, tobramycin, vancomycin, all require drug monitoring. And it's all to prevent toxicity. And we want to ensure that they're actually getting their medicine, it's in the therapeutic range, and that we are not allowing harm by having an accumulation of the med to the point that they're in toxic levels. All right, so I think I probably again got ahead of myself. So for pediatric patients, the dosage adjustments expected during growth. We have to measure liquid medications for them using milliliters. You have to, again, use appropriate dilution. You want to verify your dosage prior to giving it. And aspirin use is linked to Reye syndrome, so most children, we don't give aspirin to them. They'll use Tylenol or something other than that. Allergic reactions occur rapidly in children, so that's, again, these are just general principles that you are going to apply to the care of a pediatric patient when you are administering medications, because, you know, we have to have parameters, and we have standards of care, but there are parameters that can be placed on medications. So we are going to be looking specifically for some of these things, and how do I want to say it? You can use the same monitoring parameters, but you know, these are vital signs: urine output, renal function test. That's all used to plan dosages and to monitor the effects of drug therapy. That's used in patients of all ages. But then our children and our very elderly, they usually have some little extra thing in there too, because they're more susceptible. Again, with all medications, patient education, patient education, patient education. It is so important. Use the teach-back method with them, because you have to know for sure that that parent or the significant other, their family member, and the patients themselves actually understand what they're taking, when they're supposed to take it, and what signs and symptoms they should be reporting to their healthcare provider. Again, you want to also keep in mind that patients' cultural beliefs and practices, and that actually, again, might differ from our healthcare provider, because, you know, we might have two different worldviews going on here, and we need to negotiate a compromise. For our geriatrics, we want to complete a thorough drug history, including prescription, over-the-counter, herbal medications, and nutritional status. So, and be sure you ask them supplements. Say supplements, because sometimes they don't understand some of the things that we say. So make sure that they understood the question you're asking them. We also need to evaluate their vision and motor skills. And when you're evaluating a new symptom, determine whether it was induced by a medication already prescribed. So if you have a geriatric patient who's having dizziness or they're falling, the first thing you need to look at, besides their physical exam, is look at the medication, because a lot of times it's a medication that's causing the problem. In our geriatric patients, we do start with smaller doses and then gradually increase. You want to keep your keep a multi-drug regimen simple. You know, if you have a patient who has one medicine they're supposed to take 4 times a day, and you have one medicine they're supposed to take 2 times a day, and another medicine they're taking 3 times a day, you're not going to get very good compliance because they get really, really confused. And it takes someone to, you know, they don't always remember, and they can get, that's where we get into drug overdoses or over-medicating because they didn't understand it. So they really do try to keep multi-drug regimens simple. So, you know, like once a day, that twice a day. They really try to keep those multiple times a day, so 3 and 4 down, if at all possible, because it's easier for people to take medicines if they're just taking it once a day or twice a day. So you need to also look at to see if any of these medications can be discontinued, because what happens is you get a geriatric patient, they go to one doctor and they get this prescribed, and they go to another doctor and they get this prescribed, and then they go to another doctor and they get this prescribed. And there's not always the best communication between all the doctors that that patient may see. So what happens is then they get this collection of medication, so they have polypharmacy basically, and which is a lot of multi-drug therapy. And sometimes they can be repetitious, and sometimes the patient uses more than one pharmacy. So that's where you get into, that's where they really get into problems. So we have to review those medications. We want to reconcile them, make sure that we actually know what the patient's taking, all of them, everything, over the counter, the herbal supplements, everything. And then you have to assess the ability of the patient to actually pay for their medications, because you know, if you've got rent to pay, if they've got rent to pay, they've got medicines to pay, they have groceries, because you know everybody does like to eat, then you know you have to make sure that they can actually pay for the medications. Some medications are relatively cheap, other medications are extremely expensive, and you also have to kind of be a little bit savvy on Medicare and Medicaid, because in insurances in general, because sometimes, such as if they're on a Medicare D, there is a thing in Medicare D called the donut hole. And that is a period of time where the patient is actually paying for all of their meds out of their own pocket for that one period of time. And then their insurance kicks back in again, and then they're just again paying down that just a small portion to none, and the insurance is picking that up. So you really have to pay attention to what is going on financially with the patient. Let's see. Anything else here I need to go over with you, whether it's peds or geriatric? In your book, you have a listing. Make sure you read over your general principles that apply to the pediatric patient. It's very clear. I want to make sure that you look over that oral and parenteral medicines are available in powder, have to be diluted properly. This is a reconstitution. We're going to practice more on that. But you do need to know that, that hyperosmolar solutions can cause diarrhea and dehydration. So that would be especially important for our pediatric children. We don't want to cause an electrolyte imbalance. And then in our geriatrics, make sure that you, in your book, that you have the selected guidelines for the administration of oral meds to peds patient, that box 3.1. I suggest you know that one really, really well. Your lifespan considerations, that's your polypharmacy. Let's see. And again, remember when I said we started a lower dose, in your book it says start at 1/3 to 1/2 the normal adult recommended doses. You should see that in your geriatric patients, and you may see them up to the routine dose, but usually when they're starting out on a new medication, they started at a lower dose and then work it up to so that they can make sure that the patient can tolerate it. Another thing that you want to look at is table 3.4. This is a list of medicines. It's just a partial list of the Beers criteria, which is used to evaluate prescription quality and safety in nursing homes. Since you are in long-term care facilities right now, they do use this. This is potentially inappropriate medications for the elderly. So this includes medications that should be avoided and those that are rarely appropriate. Some barbiturates, benzodiazepines, and some narcotics. Now, if you look on here, I still see Klonopin used there, and I'm not going to tell you that you'll never see some of these medicines used on or in the elderly population, but I'm telling you there should be very, very good documentation as to why they're taking it and why this drug is the most appropriate for them, because states in general are very strict on making sure that if the patient is on it, the doctor's aware of it. Are they being weaned off? Are they trying, or is the physician at some point trying to wean them off of it, get them to something else that's more appropriate, those type of things. Geriatric and peds both can have difficulty swallowing large tablets, or children, I should say, really, have trouble with tablets and capsules. So for the elderly, you want to make sure tablets need to be broken in half or crushed if there's a score marked on the tablet. The timed release tablets, the enteric-coated tablets, sublingual tablets should never be crushed. Okay? So kind of look over your the Beers criteria over here, this table 3-4. You need to look at that, and you should probably be familiar with some of those medicines, especially those rarely appropriate medications. All right, so here's some questions. Which patient has the greatest percentage of body water? A, B, C, or D? The answer is C. Next question. Which type of topical drug is more readily absorbed by infants? Fat-soluble, water-soluble, emollient, or protective? Again, the answer is B for water-soluble because they have a higher water content. And then which form of medication is more easily administered for the toddler who requires a course of antibiotics? Enteric-coated, capsules, tablets, or liquids? Liquids, D. Another question. Therapeutic levels of drugs are important to maintain in order to avoid the complications of being over or under medicated. So if a drug level of 0.5 to 2 mg per ml is considered therapeutic, a drug level of 0.45 mg per ml is considered to be what? A, B, C, or D? It is C, subtherapeutic, because it hasn't reached the 0.5, right? Okay, let's see. Audience. Oh, sorry. Next question. Due to the decreased protein binding capacity in preterm infants, what adjustment in dosage of protein binding drugs would need to be made? A, B, C, or D? Okay, and this answer, B, the dosage should be increased. I don't know if I read it to you or not, but you can read. Let's see. I'm not here. Okay. Gender and absorption. Again, female stomachs empty more slowly, the gastric pH is greater, and alcohol is absorbed faster. Again, gender and metabolism. Remember that CYP3A4, that's a component of the liver. Those are enzymes that actually break down, metabolize the drug, and it is more active in women. Now, pregnant patients. Pregnant patients. The fetus can be exposed to substances in the mother's blood. And tetragens, remember that word, tetragens, we talked about it earlier in Chapter 2. These are drugs that can cause abnormal development of fetal tissue. So again, we would have to do some big patient education on for women who are taking a teratogenic type of drug, that they should practice birth control and carefully so that they don't become pregnant because of the medicine. All right, in pregnancy, the FDA started requiring that all medicines be assigned to a youth in pregnancy category. So we're going to go over those categories. There is A, B, C, D, and X, so that providers would know if this medicine could potentially harm the baby as it's growing in utero. Most of the time, drug therapy is avoided during pregnancy, if at all possible, but sometimes that's not always the case. So general principles that apply for you as a nurse to care of pregnant women include making sure that you've taken a good history. You want to be alert to the possibility of pregnancy in any woman of childbearing age, complete a drug history, complete a thorough nutrition history, instruct your patients to avoid drugs in general at any stage of pregnancy, if at all possible, unless it's recommended by the patient's physician. Advise against the consumption of alcohol during pregnancy, and excessive use may actually cause the child to be born with the fetal alcohol syndrome, which is a lifelong condition that simply can be avoided by eliminating alcohol during pregnancy. Advise against the use of tobacco as well. Mothers who smoke really do have a higher frequency of miscarriage, stillbirths, premature birth, and low birth weight infants, which puts the baby all at risk. Before they use medicines, you need to advise your pregnant women, patients to try non-pharmacological treatments, such as if they have morning sickness, have them lie down when they feel nauseated, ingesting crackers, sipping small quantities of liquids before getting up, or eating small frequent meals that are high in carbohydrates, and lowering their fat content. Avoid spicy foods and dairy products and smells or situations that might cause vomiting. And then herbal medicines have not been scientifically tested in women during pregnancy, so they should be avoided as well. So you're going to find these categories for the pregnancy category. So let's go over them really quickly here. A means it's okay. Adequate, well-controlled studies in pregnant women have not shown any increased risk of fetal abnormalities. And all drugs have a listing for pregnancy categories. B, I'm sorry, went ahead of myself. B, animal studies have revealed no evidence of harm to the fetus. However, there's no adequate and well-controlled studies in pregnant women or animal studies that have shown an adverse effect, but adequate and well-controlled studies in pregnant women have failed to demonstrate a risk to the fetus. Come on. C, animal studies have shown an adverse effect, and there's no adequate or well-controlled studies in pregnant women. No animal studies have been conducted, and there's no adequate and well-controlled studies in pregnant women. Category D, studies show adequate, well-controlled, or observational, and in pregnant women they have demonstrated a risk to the fetus. So by the time you get to category D, you are having risk to baby. But sometimes women do take these medications as prescribed because the benefits of the therapy outweigh the potential risk. X, now in this, in the animals or pregnant women, these medicines have demonstrated positive evidence of fetal abnormalities. So the use of the product is contraindicated in women who are or may become pregnant. So I've already kind of gone over this already. Drugs that are known to be teratogenic that actually do cause harm are androgenic and estrogenic hormones, ACE inhibitors. This would be like atenolol. Vitamin A, warfarin, angiotensin II receptor antagonist, anticonvulsants, anti-manic agents, antithyroid, chemotherapy, statins, and cocaine. This is important to know. You need to know your drug classifications that are known to be teratogenic. So when we use of monitoring parameters in breastfeeding infants. So, you know, many drugs can enter the baby via the breast milk of nursing mothers, and they do have the potential to harm the infant. So some general principles that we need to follow as a nurse include it's always best to discuss all the medicines mom is taking, whether it's prescription, non-prescription, herbal products, and make sure they talk to their doctor about it and ask them should they be taking it before they actually start taking it. So, but if the medicine is to be taken, encourage your moms to take her medicine either immediately before the baby, immediately after the baby has finished breastfeeding, or just before the infant has a longer sleep interval. So, you know, educate your mother about what the adverse effects might occur in your infant so that she's on the watch out for that. And you know, sometimes other therapy has to be considered. Genetics, study of how living organisms basically inherit the traits of their ancestors, including function of metabolic pathways. Pharmacogenetics is the study of how drugs respond, may vary according to inherited difference. And then significant differences can occur among racial and ethnic groups. So basically, you already know what the study of genetics is, but a genome is really a complete package of genetic coding of an organism. You know, we are composed of 23 chromosomal pairs, 22 which are autosomal pairs, and then the remaining is the X or the Y, which, you know, tells us if we're going to be girl or boy. All of our traits are carried in the DNA. And of course, that's the instructions for building and operating us. I don't like the use of organism. But anyway, polymorphism, that's a natural occurring variation in the structures of the genes. And, you know, this is an unfolding, the pharmacogenetics is an unfolding genetic field. And so your book explains it quite well. It doesn't have a lot, it doesn't go into a big depth, but it's a really big field of genetics are really opening up as far as how we give medicines, how medicines can be basically made to our DNA, to our genes that helps us along. So, and it's based on a lot of different factors, such as your age or your gender, your organ function, all these things. And you've heard of monoclonal antibodies before, and that, you know, we do have medicines that are monoclonal antibodies, or monoclonal medicines. So, you know, the genes are kind of taking over the world. Eventually, there'll be more and more of them. You'll, as you advance in your career, you'll see more and more of that come into being. So let's see. And I believe that's it for this chapter. I know it's a lot to take in, but again, it's all about ADME, absorption, distribution, metabolism, excretion of the drug, and how the drug affects the physiological activity within the body. And then we, of course, are always monitoring for the desired effect. That's what we want to see, the desired effect. We want to minimize those side effects and adverse effects. So I will talk to you later, and I hope you have a good weekend.